Good evening and welcome everyone. We are thrilled to host you at the Consteel Impella webinar, proudly presented by Veiva Scientific. This platform brings together global experts to share insights on advancements in cardiovascular therapies. We are privileged to have a distinguished panel of interventional cardiology leaders here with us today. Moderating the session is Dr. Ashok Seth, Chairman of Fortis Escorts Heart Institute, New Delhi, renowned for his expertise and leadership in the subject. Our guest faculty and keynote speaker is Dr. Rajiv Dayal, Director of the Cardiac Catheterization Laboratory and Structural Heart Program at Valley Health System, New Jersey, USA. Now, I invite Dr. Ashok Seth to lead us into an enriching session. Over to you, sir.
Thank you very much, dear friends. I hope you can see me and hear me well. I'm going to share the screen for a bit only to set the stage for what I say is a very important subject. If you can see my screen, I'll confirm the fact that you can see my screen.
We can see the screen very well.
So, in the present era, it's quite clear for us that complex and high-risk PCI is what used to be a learning experience and somewhat an unusual experience as 15 years ago is a common ground for all of us. And it's not just the specialists and the experience who are dealing with complex PCI. Unfortunately, and in some ways, it is fortunate for the patient that our frontline young gen interventional cardiologists are in tier 2 and tier 3 cities and are faced with highly complex PCIs landing up on the table with an ACS and therefore deal with it with courage and with giving the best outcomes. And therefore, it's becoming important for us, all of us, to learn from each other, talk to each other, and really move into the direction of not just complex PCI, but also how to keep our patients safe and how to give them an effective and complete revascularization. So the CHIP PCI has become a part of an integral training process for all of us as we move on to the younger generation interventional cardiologists so that we can deliver the best outcomes to our complex patients. Today, of course, in this present era, there's an increasing interest in supported PCIs, which allows us for safety and complete revascularization of these patients. And of course, I just want you to take through. Today, we're going to discuss Impella supported PCI, one of the mechanical circulatory supports available to us. And of course, we do realize that a greater interest is drawn into Impella because it is physiological, because it's effective, and because it's probably the only proven device in a randomized trial of all the mechanical circulatory support, be it IABP or be it ECMO on one side and IABP on the other side. Impella, in the recent danger shock, proved its efficacy in terms of cardiogenic shock. And therefore, as we move ahead, supported PCI becomes an important arena. And just a flashback on this, of course, takes me back to when Impella got used in Asia Pacific. And this is when it got used in Asia Pacific. It's a throwback on 18 years ago, April, 18 years ago, when I did the first supported PCI in Asia. It was practically one of the first outside the United States as well, when Protect One study was on in the United States at the moment. And this was in an 83-year-old male who had coronary artery disease with angina and had an angiogram prior, 15 years ago, where he was revived bypass surgery. And then he had a STEMI and went into cardiogenic shock. And this was in Jaipur. And we transferred him on a ventilator in LVF with an ejection fraction of 30%, hypotensive. Those are his EKGs, and those are his PAs and systemic pressures. And you can see that this guy was at peak. His aortic pressures were something like 75/40. And that was bad triple vessel disease. He had left vein, he had triple vessel disease, right coronary artery disease, and on Impella supported PCI, stented left vein and the right coronary artery, and also down the LAD. Now that's what you see here. Complete revascularization in this cardiogenic shock patient, airlifted on balloon pump and ventilator, and 5 days later, he was discharged from the hospital. And of course, that brought in the era of supported, or not just supported PCI, say, Impella for cardiogenic shock for Asia. And in 2007, by the time we transmitted to the TCT, we'd done 15 Impella cases. And you see the ejection fraction, the mean ejection fraction is 38.1. 6 of these patients were in cardiogenic shock, and left brain triple vessel disease was common. Mean duration support 2 days, procedural complication nil. And I was invited to present Impella to the main arena of the TCT in 2007, which was the first ever live demonstration of Impella to the main arena of the TCT ever. And of course, there's Marty Leo moderating that session while we're transmitting it at 12:30 at night. I don't know how I'm keeping my smile alive when the patient had 20% ejection fraction and arrested 5 minutes before the live transmission came on. And of course, that was the highlight of the TCT when Jeff Moses in the cardiac theater said it was a beautiful demonstration of the most treacherous cases that he'd ever witnessed with 20% ejection fraction. That's Impella, and that's us performing it. Thankfully with smiles, which obviously confirms that patient was doing well in those circumstances. Well, of course, Impella went out of our hands as soon as it got approved in the United States in 2009, I think, 2008 or 2009. And of course, then we reintroduced it back into the country, thanks to ABMed and our cooperation and collaboration with them. And of course, this is, I think, what comes to the crux of the matter is going to be where Raj Dayal has been closely involved with us as one of the co-directors of the CHIP CTO India meeting, which we started in 2018. But more importantly, we have a purpose with the CHIP CTO India meeting. Those of you who attended it, and most people love this meeting for not just its content, but also the exchange of ideas, the exchange of sharing of expertise and sharing of knowledge, but also practical education to our younger generation of interventional cardiologists, is the fact that in 2020, we created a scoring system for supported PCI. And while scoring systems have existed around the world, and one of those ones is the University of Washington scoring system, and Raj also has been involved in scoring these patients for supported PCI. When we sat down between us, which also includes Raj Dayal and Sanjay Kalra, and 16 of others, experts from the country, we sat down and thrashed over a period of 6-7 hours a scoring system which we developed for the country. And of course, Raj Dayal is the first author of this, Raj. And this, of course, is the expert document which has been published. And how does it influence us? Well, this scoring system and the score greater than 5, we strongly Impella support. And by the way, that's how we go about it. This is for high-risk PCI, and the assessment is done by us. We go through the scoring system, and it's a very important scoring system, looking at the hemodynamics, looking at patient characteristics, looking at the coronary anatomy and its complexities, and looking at procedural characteristics. And when we go through that, we differ from the University of Washington score by extending the syntax score to 32 and not just 22, because we do have complex multivessel disease more commonly. We've excluded low hemoglobin as one of the scoring points. For less than 25% ejection fraction, we include 2 points. For ages of more than 75, we've added a point. I won't go through the details of this, but make you understand that we actually use the scoring system. We validated it. For us, a score of 3 to 5, we may consider intra-aortic balloon pump, and for scores of more than 5, we strongly consider Impella support. And by the way, this year, we've developed a document for the management of cardiac shock in India, which is right here, printed, which is going to be circulated to the 25 experts who stand and actually took part in this document. The first cut is out and is going to be sent tomorrow to everyone to review. With these words, I think there's a lot to talk about, a lot to discuss, and a lot to move ahead with. I don't want to take up Raj's time, but to just say that together in this country, we've grown in supported PCIs, especially with the use of Impella. There are challenges, there are limitations, and we have a variety of financial constraints. but science comes first. And today it's all about science. Today it's all about knowledge. And today it's all about sharing. And with that, I'll pass you over to Raj to take us through the talk, Raj. And I must introduce, by the way, at the same time, that we have great experts here. While Raj is well recognized all across the world and has been responsible, by the way, for percutaneous transaxillary approach, he defined it and he taught us that as well. Raj, thank you very much for doing that, even with all the friendship and the support we've had from you. Today we have on our panel, we have Rakesh Jaiswal from Chandigarh. We have Suhas Sardas from Ruby Hall Clinic, Pune. Harish from Mumbai. Selvamani from Madurai. We have Arun Srinivas from Mysore. We have Sanjeev Sharma from Jaipur. And we have Singotuvelu, my close friend, I'd say, from Chennai. All of you are great friends, by the way, but I somehow have special liking for Singo. And of course, speakers, Ajay, always been tremendous, always very scientific. Naveen Bambari, continue to do the good work at the Max Hospital in New Delhi. Shafiq and Kozhikode has been taking real great strides in complex PCIs. And of course, Dhananjay Kumar from Ranchi reflects our early career interventional cardiologists being on the front end, facing the flak, and yet doing one of the most complex cases without great support as we have in our big centers. With that, I hand it over to Raj. Over to you, Raj.
Thank you so much, Dr. Seth. It's always an absolute pleasure to be with everyone, and thank you all for joining us this evening. Dr. Seth, it's always a privilege to hear the past, the present, and the future, and all the work that you've put into developing this field along with your colleagues is truly tremendous and really inspiring in the name of improving patient outcomes across the globe. So I'd like to share a presentation with you all that I've put together. Just let me know if you guys can see this properly.
See it, Raj.
Entitled Protected PCI, Defining the Right Patient, Right Therapy, and the Best Outcome. And so I wanted to do so in somewhat of a case-based format and share some experiences that are personal cases of my own. And so prior to doing so, I want to just put up a disclaimer in the sense where at any conference, whenever we're talking about procedures and cardiologists specifically, there's a general rule of thumb. So when the speaker says this procedure was done at an outside hospital, that typically means it was done by the speaker's partner and the overall outcome was bad. When the speaker says it was done by my partner, it's typically done by the speaker and the outcome was still not the greatest. However, when it says it was my case, obviously we only show the best and the greatest. But the point of this is not to do that per se, but also just kind of shed some light on some things. So beginning with the first case that I'd like to share with you all, this was an 82-year-old female with your standard comorbidities, including hypertension, hyperlipidemia, type 2 diabetes mellitus, CKD. She's known to have severe peripheral vascular disease and a prior history of a carotid endarterectomy. She presented to the ER with severe shortness of breath and abdominal discomfort. In the ER, she was found to have a new left bundle branch block, and her initial high sensitivity troponin levels were greater than 25,000, suggesting an acute on chronic myocardial infarction. As you can see, she's kind of borderline shocky with a heart rate in the hundreds, a relatively soft blood pressure in the 90s over 60s, with a mildly elevated serum lactate at 3.4. A transthoracic echocardiogram was performed at the bedside. The EF, as you can see, is markedly reduced and has now declined to 20%. Based on review of the medical records, it appears that her last ejection fraction was about 50% 6 months prior. Code MI was activated and the interventionalist on call brought the patient to the catheterization lab. Diagnostic angiography was performed, and what you can see, the patient has a non-dominant right coronary artery with a very large circumflex system and a very complicated lesion of the distal left main into the circumflex and ostial LAD, which is heavily calcified. Again, here in this LAO projection, you can kind of get a glimpse of it. So I think one thing that we're seeing globally, not only in the United States, is that the overall incidence of cardiogenic shock is increasing. And I know we're going to straddle the line here in terms of this case presentation and what we're discussing, because it kind of borders on both complexities and intricacies associated with high-risk PCI in addition to cardiogenic shock. But overall, we see that the incidence of cardiogenic shock has tripled over the last decade or so, and that all patients presenting with an acute ST elevation myocardial infarction, of those, 1 in 10 will develop concomitant cardiogenic shock. Of those patients with cardiogenic shock, we know that they have a 50% mortality despite best practices in this day and age with the advancement of technology and mechanical circulatory support in most instances. I think something that's often under-recognized or appreciated is the fact that about a third of these patients also exhibit a certain degree of right ventricular dysfunction. Any patient presenting with a concomitant degree of right ventricular dysfunction is known to have a threefold increase in overall mortality. Now, what we've seen is that when you're looking at cardiogenic shock, there's been multiple ways and multiple studies that have looked at outcomes when you just perform PCI without hemodynamic support, whether PCI is performed with the use of intra-aortic balloon pump counterpulsation, and more recently with the utilization of Impella devices placed prior to intervention. What you can see is that the overall statistics suggest that there is a significant improvement in survival to discharge when appropriate mechanical circulatory support is deployed prior to intervention. So when no support is used or even balloon pumps are used, you see the survival rates are in the 40th percentile. And based on the CVAD registry, you see that those rates go up to the 65th percentile when Impella is used prophylactically. Now, something that's also important in the risk of high-risk PCI, or in the realm of high-risk PCI rather, is when you look at the outcomes of patients undergoing high-risk PCI, you can see that the overall mortality for patients surviving to discharge is only 4%. However, when mechanical circulatory support is deployed in a bailout situation in surgically ineligible patients, you can see that the mortality rates approach 60%. So there's over a tenfold increase in adverse outcomes. Now, when you look at a larger meta-analysis outside of these single, registry data or whatnot, these meta-analysis of over 15 different studies, over 1,500 patients, there's not one single predictor that suggests that there is a benefit of MCS after intervention or during. All of these studies suggest significant benefit prior to intervention to avoid hemodynamic compromise. I think one of the other things that's important to recognize is that there have been several studies that suggest that even though patients are deemed surgically ineligible, there is a significant mortality and a benefit in their patients' overall KCCQ scores, including anginal frequency and overall determined quality of life. So as we look at considerations that we typically consider and deem patients to be high risk, we're talking about your kind of defined things that increase in hospital mortality, including surgical ineligibility, CKD, impaired LVEF, as well as severe calcification, all of which the patient that we had initially presented kind of are presenting with. Now, Dr. Seth had alluded to the recent publication of the Danger Shock trial, which is the first randomized control clinical trial which shows a significant benefit with the use of an Impella CP device in the setting of cardiogenic shock acute myocardial infarction complicated by cardiogenic shock. Again, what we see is that this study was performed over a 10-year period, and the overall number of patients that were included was 355. Their mean age was 67 years, 80% of which were male. The median onset of treatment from symptoms to randomization was 4 hours. And you can see that these patients were quite sick on presentation with a median lactate of 4.5, an EF of 25%, and a systolic pressure in the 80s. A majority of them had LAD or left main equivalent disease and presented in SCAI class C or greater cardiogenic shock. Now, I think the most important thing to take home is basically you had an absolute 13% reduction in mortality with a number needed to treat of just 8 patients to save 1 life. If you decrease the age of patients, all patients under the age of 70, that number needed to treat further improves to 5 patients in order to show an improvement. Now, in contradistinction to previous shock trials that had been performed looking at the utilization of balloon pumps and/or ECMO, you can see that there was no difference in 30-day mortality, whereas again here, even out to 180 days, we see a 13% reduction. So back to the patient that we had initially presented, what was done in that setting is the patient was evaluated by cardiac surgery. They were turned down due to the acuity of their illness and comorbidities. Access was obtained in the axillary artery. As you can see, the periphery here has severe diffuse calcific disease throughout. However, there's something that we've defined called the axillary paradox, wherein the rates of obstructive peripheral arterial disease specific in the axillary artery is only 1 to 2% in most of the population, compared to around 11 to 15% in the legs. So an Impella CP device was inserted percutaneously, and the baseline hemodynamics are something that I think need to be appreciated. You can see the right atrial pressure was 18, the PA pressure was 57/40. You had a PA saturation of 38% with an index of 1.5. However, shortly after going on hemodynamic support, we took the time to electively intubate the patient. That's not necessary for percutaneous access, but just for hemodynamic stability, we opted to do so. You can see that the cardiac index improved within less than 5 minutes to 2.4 liters per minute meter squared. We were able to get an 8 French guide up from the femoral arteries, and again, you can see much more clearly the degree of disease as well as severity of calcification in multiple angiographic views here. Ultimately, what we opted to do was proceed with rotational atherectomy from the left main into the circumflex with our standard protocols at 180,000 revolutions. We did take our time here, and you can see that the burr was advancing quite nicely without a lot of resistance after the initial drives were made through and/or passes. Again, multiple passes were made here. We felt like there was no real resistance or decelerations. So ultimately, we opted to try to remove the burr and move on with our PCI. However, on removal, the burr became entrapped within the left main coronary artery. And despite having the rotaburr stuck in the left main, the important part here is, number one, we had a Swan-Ganz catheter in place, but you can see that the patient's hemodynamics index and saturations remained totally stable throughout this ordeal. So the typical kind of tips and tricks were employed, including manipulation of the system, the rota system. We ultimately opted to double wire the circumflex, used a balloon to balloon distal at the site of the burr entrapment and proximal to it with no success. Ultimately, we took a 7 French guide liner after cutting the rota drive shaft, and then ultimately abutted the device with the guide liner. We had a parallel wire again placed distally in the circumflex, and then we're able to safely remove the rotaburr. Again, the patient's hemodynamics remained totally stable during this entire exchange. And here again, you'll see that the burr is able to be withdrawn without any significant adverse sequelae. Again, from there, we actually yelled at the Boston Scientific reps, grabbed a brand new rotablator, and went on to perform atherectomy into the left main and LAD. We ultimately, you can see after rotational atherectomy, had a significant improvement in overall flow and filling, and then ultimately proceeded with the rota shock algorithm and performed shockwave lithotripsy, and then finished the procedure with a culotte stenting technique. Again, you can see the patient's hemodynamics were stable throughout. However, given the fact that the patient was in borderline shock with an elevated end diastolic filling pressure, we opted to leave the Impella in place. There's multiple mechanisms to secure the device, which we can talk about beyond this. But after removal of the device in 48 hours, you can see the ejection fraction had recovered. The second case I would like to share with you all basically is somewhat also equally, if not more so important. This was an 85-year-old male with a history of the same comorbidities, hypertension, hyperlipidemia. He's a diabetic, stage 3 CKD, was found to have polymorphic VT and presents with the left bundle and mildly elevated troponins. You can see the blood pressure is relatively stable here. The lactate is normal, so this is kind of a non-shocky situation. Again, here are your baseline hemodynamics. You have a blood pressure or a mean arterial pressure of 97. The right atrial pressure, again, is elevated. PA pressures are elevated with evidence of volume overload and a significantly elevated pulmonary capillary wedge pressure of 40. Despite that, the cardiac index with thermodilution was 2.25 liters per minute. You can see the patient has mild to moderate concomitant valvular heart disease with an EF of 25 to 30%. So the baseline angiograms show, again, diffuse disease, a similar kind of anatomic orientation. Again, you have a non-dominant right coronary artery, a large dominant circumflex, a lot of calcium throughout the circumflex and LAD. Again, I think here the culprit and the difference was the mid to distal LAD was diffusely diseased and heavily calcified throughout. So what was opted to be performed, and again, the first case was my case, and going back to the first slide, this case was actually my partner's case, and he ultimately opted to defer using a Impella support in the setting where the patient had peripheral arterial disease and was concerned about the risks of vascular complications. However, upon engaging the left main, just the simple fact of engaging the left main, taking one contrast shot, the patient rested. So he ultimately upsized the arteriotomy, emergently placed an Impella, and then opted to go ahead and proceed with rotational atherectomy of the LAD, despite, after relative stabilization of the patient hemodynamically. Again, atherectomy was performed, and this was done ultimately to kind of decrease the need for serial balloon dilatation. Again, you can see that there was TIMI 3 filling afterwards. Several attempts were made at additional balloon dilatation. However, under expansion was appreciated. Accordingly, shockwave was done. However, all the pulses of the device could not be delivered due to intermittent hemodynamic instability. A stent was deployed basically from the distal left main into the LAD, and you can see that the overall result was probably somewhat suboptimal, but there's TIMI 3 filling throughout the LAD and circumflex. The decision was made to leave the Impella device in place and send the patient to the CSICU for recovery with a Swan-Ganz catheter in place. Unfortunately, so what happened to this patient? They were transferred to the CVICU, like I talked. They actually had the ongoing requirement of additional vasopressor support in addition to hemodynamic support with the Impella device. They developed recurrent runs of polymorphic VT with worsening hemodynamic stability and end organ perfusion. They were intubated about 12 hours after the procedure with ongoing increasing pressure requirements and ultimately expired 3 days later. Again, this kind of speaks volumes with regards to the benefits of providing support prior to the intervention as opposed to post, and also goes back to this meta-analysis that we had showed where there's basically all studies suggest benefit prior to intervention. Now, when you go to the algorithm Dr. had alluded to, and you calculate this individual's overall risk score, you can see that the calculated score, when you're calculating the benefits of MCS or suggested utilization of MCS in the setting of high-risk PCI, this patient's score calculates to a total of 8, which is far beyond that which we recommend considering support. So the main question becomes is what is high risk and or complex PCI? And I think that there are multiple definitions across multiple publications and everybody has their own perspectives on it. You can see that there's different algorithms as we've alluded to and different criteria based on different institutional preferences, whether it's University of Washington, Mount Sinai, New York, etc. There's been a number of these Venn diagrams that have been suggested to utilize as considerations and associated outcomes in terms of mortality risks. However, when you look at publications, this is the largest one that I was able to find to date of almost 2,000 patients. What you can see is that the strongest predictors of short-term MACE were basically patients that had New York Heart Association Class 4 heart failure, systolic pressures less than 190, creatinines greater than 1.3, pulmonary pressures greater than 50, left main disease, or interventions that were performed on the last maining conduit. So really, the next question becomes for all of us to keep in the back of our minds is what are the biggest predictors of hemodynamic instability during high-risk PCI? And the answer is actually the overall BESIS JS score, meaning the overall myocardial jeopardy score, in addition to the left ventricular end diastolic volumes. So when you look at these things, these actually are most accurate in predicting the overall incidence of instability throughout the procedure. Now, it's important to recognize that when we're looking at this, hemodynamics are paramount. Of course, identifying the patient's cardiac power output, which is simply mean arterial pressure multiplied by cardiac output divided by 451, is probably one of the strongest predictors of survival as well as hemodynamic stability. But the goal, again, is to provide adequate support and get these numbers to greater than 0.6 at all costs. So pre-procedural optimization, MCS prior to the intervention, and aggressive escalation is recommended post. So in the case that I displayed, the second one, what we see is the CPO was 0.7 prior to the intervention, the PAPI was 1 prior to the PCI, but really dropped to 0.4 after even after the insertion of a mechanical support with Impella. So further escalation probably should have been considered post-arrest and prior to transfer to the CV-ICU. This is somewhat unvalidated, but again, it's just something that we've experienced anecdotally during our high-risk interventions. There's always a question as to whether we wean the Impella device in the catheterization labs. What we typically recommend is not weaning the device if you see a drop in PA saturation by greater than 10%, a drop in the mean arterial pressure by 10 millimeters or more, or an increase in end diastolic filling pressure of greater than 10, or base pressure greater than 30 millimeters of mercury. Thank you very much for your attention.
Thank you very much, Raj. I think it was very comprehensive, and the two cases truly reflected not just the thought process which goes behind the treatment of these high-risk patients, but also the learnings in deciding prediction and sort of preempting disastrous consequences of our complex PCI. So I think I'd put this now open for discussion, both expert panelists as well as speakers. Questions, queries? Raj, one of the most important aspects, as I say, is while insertion and maintenance of Impella is a key aspect in many of the scoring systems that we have. And I'm not just talking about cardiac shock, we talk about supported PCI. One of the important aspects is managing Impella and its subsequently. I mean, that's what danger shock told us, that in that cohort, firstly, of course, there's this elderlies who did pretty badly. And then the other group was the complications of Impella. And all these were expert centers, and yet they were complications of Impella as patients were shifted and over the next few days. So I'd like you to comment on that. That's an important aspect of learning.
Absolutely. There's always a degree of, there's a learning curve associated with the utilization of any large bore device. Access remains a real thing that needs to be monitored. When you look at the results of the DANGER trial, you see that the overall rates of vascular complications were around the 20th percentile. And different companies and different people will spin it in different directions. Those vascular complication rates are no different than what you see in IVP shock, the ECMO trials, et cetera. So that needs to be considered strongly when we look at all these patients. However, providing the appropriate support also has a notable benefit in survival. So it's really mitigating and balancing these two issues. I think the application of best practices for vascular access, pre-closure, utilizing some of the more refined techniques, whether it's putting 2 percloses up front or 1 perclose, and then combining that with a collagen-based device afterwards, completion angiography, these things all really make a big impact. In addition, I think that early recognition of limb ischemia is very, very important. So having the ability or knowledge to place distal perfusion cannulas when patients are on support but still requiring some vasopressors and are very vasoconstricted are all critical learning points and things that everyone should be facile with prior to using the device.
Thank you. Over to the expert panelists. Jaswal, comments from you, Selvamini, Harish, and Suhas.
Yeah, you see Sky shock stage E, do you use only Impella or Shockpella? Impella plus Ec- Ecpella.
So I think that's a great question. It's important to realize and recognize that the Impella device is not a Lazarus device. It's not meant to rescue people that are, with out of hospital cardiac arrest or fulminantly in shock, despite maximum vasopressor therapy. What I would suggest and what we typically do is we do start patients on ECMO, and then we'll use an offloading strategy so that the ventricle doesn't get blown out. Some people will advocate for the utilization of a balloon pump in that scenario. Oftentimes, we will go to an ECPella strategy. We're actually currently doing a lot of research looking at the use of LAVA ECMO, which is left atrial veno-arterial ECMO, because it's relatively cheap, it's relatively easy as people have gotten more familiar with doing transeptal punctures, and it prevents the increasing pressures in the left ventricle.
Raj, it's interesting that the majority of our patients of supported PCI or protected PCI are clearly those patients who universally got LV dysfunction, have had recent MIs or remote MIs, have been in pulmonary edema and have come out of it, but have low ejection fractions, high PA pressures, borderline PSATs, but still are not on inotropes. So they cross between, and that's what I say, that this is a distinct population from those really supported PCIs who may fall into the score, but may have a reasonably good LV, but just have triple vessel left main calcific disease and require atherectomies, etc., and still fall in that score of prediction of adverse events, or in the cardiogenic shock, where it's far more difficult for us to use as a life-saving device due to financial constraints and availability and so on and so forth.
Of course.
So a lot of exactly the case you presented as case one is exactly that borderline situation where a guy is not rising his lactates, he's not on, or he may be in minimal inotropes, but no, or no inotropes, but he's a bad case because the moment you put a device into his left main, he could crash because he's got his borderline PSATs, his PA pressures are up, he's just got a systolic of 100, he is tachycardic, and you just got him out of a left ventricular failure following a recent MI.
And that too, when you get into a complication like a rota burst stuck, you have Impella in place and it saves the day.
Well
So
done.
my question is, you had put the rule of 10, Raj, you were telling about that. And you said the mean arterial pulmonary artery pressure, if it falls more than 10 millimeter, we should not wean off. Why I expect a fall, but if it falls more, what does it indicate?
PSATs, he said. A fall in
PA
PSAT.
He said PA stat and next he said PA
Stats.
pressure.
Map.
No,
Can you show that
mean
screen
arterial
if you don't mind?
MAP.
Oh,
mean arterial.
That's
Yeah.
right.
Mean arterial pressure. Okay.
Yeah.
Okay, fine, sure.
And
So-
looking at the data sets that they're coming up with from Protect 4, they are coming up with a much more refined system to kind of predict when it's, to come up with weaning protocols in the setting of high-risk PCI. My feeling on this is that sometimes things get a little too complicated, and keeping things simple and straightforward so that you have it in your mind when you're doing the intervention is much more beneficial to coming up with very, very calculated scoring systems to determine weaning protocols. So that was kind of the concept behind that. We're looking to validate this rule of tens between ourselves and Washington, St. Louis University and a couple of other centers now. When we're looking at these high-risk algorithms, it's interesting because a lot of them don't necessarily correlate as well as some of the other predictors that we're all totally familiar with. But the real primary issue is in the patients with high-risk PCI, what the margin of error is tremendously small. And so if there is a little bit of, microvascular dysfunction, if there's some concomitant things that we don't account for, I think that the chances of having myocardial stunning, having some different issues post-procedurally that we're really not aware of, just on purview of looking at traditional angiograms or hemodynamics, we've seen patients actually crash post-procedurally without a recognizable etiology in those settings as well.
So Raj, this is a very important aspect, and recognizing the weaning of Impella and therefore leaving Impella when you shift to the CCU. But on the other hand, yes, I actually do recommend that we, even in those, and remember that the sort of cases we talked about, they're not cardiogenic shock, but they're bad cases. They're not the 45% supported PCIs just because you had complexities of situations and cerebral dysfunction. I have a simple practice to avoid, unless it was absolutely necessary and the PSATs had gone down, if filling pressures had increased, and the fact that even while during weaning, that we weren't getting the effective cardiac power output. Apart from those, I always, as I take off Impella in the cath lab, would transfer them onto an IABP because we just believe that whatever we've done would have stunned the myocardium, we've worked so long in multivessel disease, it would have stunned the myocardium with balloon inflations, multiple balloon inflations, use of devices, etc. And there's nothing better than IBP post to perfuse the coronary arteries and perhaps improve on that stunning in the next 24 to 48 hours, because we believe that it it improves recovery and therefore decreases may improve also their rebound
I
of every
absolutely
function.
agree with that. I know there's a few centers here in the United States that do that routinely. Obviously, managing a balloon pump on the floor is much easier than the Impella device. I think the peel away sheath remains kind of the Achilles heel of the entire system, particularly if you're in the throes of an extended procedure or you're using the single access technique. If you have the device in for 2, 3, 4 hours and then take the peel away sheath, the ability for the vessel to recoil and go from 14 French down to that 9 French cannula, there's always going to be a significant amount of bleeding, no matter what you do with the positioning, the suturing. You can tie figure of 8 sutures or whatnot. So I wholeheartedly agree with that, and I echo that sentiment.
Thank you.
What do the experts feel about putting in a ProGlide before and then going down to an 8 French sheath? Leave the sheath in place, put the IBP through that at the end.
No, in answer to Ajay, you just take that off. It's always pre-closed.
Yeah.
Anyway, so you just take it off. You put the intra-aortic balloon pump through the axis. If it's not a single axis and you've got 2 axes, you just put it through the axis you did the PCI. That only comes in the time when you're doing a single axis procedure, and then you can actually do that. But also, are there any other questions? Raj, are you with us for some more time? Because as the cases get presented, I think your expertise and everyone else's discussion would be really vital.
Of course.
Raj, can I have a question for you? This is
Of course.
Suhas here.
Hi, Suhas.
This is more technical. Basically, I wanted to ask you if you have come across significant hemolysis after having had this device for longer than 3 days. And what has been your strategy to manage that? That is number one. Number two, how do you achieve the best first pass? Do you have any tips or tricks that you would want to tell us, the beginners like me? How do you achieve the best first pass? Thanks, Raj.
Of course, it's my pleasure. So one of the biggest kind of rate limiting steps for prolonged utilization of the CP device is the rates of hemolysis, because it is a relatively small drive shaft. So the overall rate of the revolutions per minute that are required are quite high. They're actually above 40,000 revolutions per minute. So the tendency, particularly when patients are vasoconstricted, to develop a degree of hemolysis is very, very high. Typically speaking, the best ways of doing that or preventing that are to ensure appropriate positioning of the device. One of the things that we learned early on in the experience that we had with the upcoming ECP device, which is Impella's 9 French system, is that really ensuring that you take the time to bring the camera over to an RAO projection and have the pigtail deep in the ventricle posteriorly, so you're in the true ventricular apex away from the mitral valve apparatus, is helpful in reducing that. I think sometimes we all say, well, I can see it pretty well in any projection and it's pretty standard. The pump looks like it's in a reasonable position. But the better your position in the apex, the actual better overall support and less hemolysis you'll have. Number two, it relates to volume. So if you're able to administer a little additional fluids, this obviously helps, and/or vasodilatory agents, or simply decreasing the P level of support, which sometimes I know we're unable to. But these are kind of the three major troubleshooting steps that you can take, aside from upgrading the device to a surgical 5.5 device, which I know is somewhat limiting.
Thanks, Raj.
Thank you. And I think Raj's expertise in auxiliary large bore access is tremendous. That's always percutaneous for him. And that's pre-closed. And so he probably thinks of auxiliary access even in some extent easier than a femoral access.
So we've actually developed a technique to put the surgical 5.5 device in percutaneously and perfuse the upper extremity as well. So basically, we've been taking the Impella RP sheath and placing that, and then putting the 5.5 device in, leaving the sheath in place, and then doing a single axis technique with a 7 or 8 French sheath and connecting that to a sheath in the radial artery with a male connector. Abiomed isn't really thrilled about me fully discussing that openly, but I think it is an option in some cases where you have refractory shock and there's really no options. As we know, sometimes getting surgical cut downs can be somewhat limiting time-wise and/or hemodynamically. They are coming up with other devices and iterations sooner, which will provide 5.5-like flow with slower spin speeds that I think will improve our ability to do long-term support shortly.
Thank you. So let's go to the cases, and we'll learn more from the cases as we discuss. So that's over to you. Protected PCI with Impella, your experience.
So I've chosen a case rather than showing our experience. We have done about 12 cases or so with Impella. And I'm going to show you a representative case that's actually a combination of everything that we've discussed so far. Is my slide visible?
It is.
This is a 79-year-old male, COPD, hypertensive dyslipidemic, had an antival MI, NST outside, managed medically, shifted to us on crescendo angina. He underwent an angiogram, and the moment his left coronary artery was hooked, he had severe hypertension, a near arrest situation. The 2 shots that were taken showed calcified coronaries with a distal left main of 90%.
Your slides are not moving unless you're moving your slides and you think they're moving. At least I don't see them moving, and you're not on a slideshow mode.
Okay. Is it visible now?
They're visible, but they're not moving.
Right. Let me try again.
And it's only your.
We can only see the first slide.
Right.
Yeah, and it's not on a slideshow.
I'm just going to try stop and then start again, if that will
That's
work.
right. You may share again.
Do we see this now?
Yes, we now see the we got to the case details. Yes, case details.
So he's a 79-year-old male, COPD, hypertensive, dyslipidemic, NSTMI interval. The moment his left coronary artery was hooked, he had severe hypotension. He had an interval MI, calcified coronaries, distal left main 90%, and an LAD and ostial, both LAD and ostial circumflex disease. He had acute pulmonary edema, intubated, IBP was placed. The echo showed a severe elbow dysfunction. He was referred for an emergent CABG. I'm going to show you the angiogram to cut the story short. But after counseling and the heart team meeting and the discussion about the risk because of his elbow dysfunction and his COPD, family refused, and he was accepted by us for a high-risk PCI with mechanical support. So the plan was to insert the Impella, modify calcium in the LAD, L6, and the LM, and do a rotor cut plus a left vein bifurcation. And this is how it began. So the IBP was already in place. So after we inserted the Impella, we removed the IBP, and through the IBP access, then started the procedure. This is what his angiogram was like. And you can see that it's a left main bifurcation that's heavily calcified. I don't know if you're able to see it. It's good, and he's got a little bit of resting tachycardia, but it's heavily calcified and eccentric disease from the ostial proximal LAD out to the mid LAD. So after the Impella was inserted, initially, we had already put in a PA catheter right in the beginning. His PA SATs were about 58, 56%. His PA mean was 50. His arterial pressure was a mean arterial pressure of 76. That's what we started with. This is a 1.5 millimeter rota burr that was used. I'm just showing you the polishing runs. It took about 6 to 7 runs before we were able to get the rota to this position. Wired the circumflex thereafter. Used a cutting balloon at high pressure, both for the LED and the L6. And I've shown the stent enhancement sequences to show that we didn't stop cutting it even after bringing it back and rotating it until we got satisfactory expansion on the cutting balloon. And the only difference from a classic DK crush procedure that we did was we used the circumflex as the main branch. We stented the mid to distal LED. And then since there was lesser discrepancy and the circumflex was huge and dominant, we decided to use the LM to circumflex as our main branch and worked accordingly. This is the stent in the mid to distal LED after the proper preparation. And the circumflex wire is placed in the aorta as a sepal wire. We've got another wire down the circumflex with a balloon for crushing the left main to LED stent. This is the LM to LED stent with the balloon and the circumflex that one can see. That is then crushed. I'm not going through all the steps so that we have a discussion at the end. And you can see that during the procedure, the hemodynamics became pretty bad, but the Impella supported us throughout. We had classic ventricular arterial uncoupling with loss of arterial pulsations and absolutely flat line. At these times, the patient was completely dependent on the Impella pump. But we were absolutely comfortable working, and it makes it much, much easier and simpler to do a proper job of preparing whatever one needs to do. Because you know that you're going to get it back. After each balloon inflation, when you deflate the balloon and get it out, the pressures would improve, the QRS would narrow, and we could go back to working the way we were. To cut a long story short, this is the first kiss, then the second stent from the left main to the circumflex. That's the final pot. We use liberal stent enhancement. And so this was our stent enhancement view. Unfortunately, on that day, we didn't have our imaging available. But this was our stent enhancement after finishing off the DK crush and the final pot. This was the angiogram that we had in all views. And that's our final shot with a perfectly acceptable left main bifurcation and good TIMI3 flow in the circumflex. The LED was already infarcted, so we did have some TIMI2 flow. Again, the same discussion about when to remove the Impella. So we waited for about an hour. Our hemodynamics improved almost immediately, but we still waited. We waited for our LVED to drop. We started at about 28 and it dropped to about 16. After about an hour, our CPO went to 1.1. Our PA SATs came down, went back up again. Our arterial pressures improved. And after waiting for an hour, we remeasured our hemodynamics. We left the sheath in place in case we need to do another, we need to put back the IABP. But we waited for another hour after that, and we elected not to do it, although we had access because it was absolutely fine. We measured our PA pressures, which had dropped significantly, and closed with a ProGlide. That was our final shot. I've rushed through the presentation because I want to give some time for the experts to comment as to what all more we could have done. There was gradual and sustained improvement. His LV function improved from about 25% to 45% over the next week. He was extubated after 24 hours, discharged after a week, and took great pride in walking out because he wanted to go back to playing golf. He's doing well in the OPD after 18 months. And it was a most gratifying kind of procedure because a patient who was practically dead and turned down from all sides actually walked out and he's back living a full and independent life, which was very important for him. We've also done plenty of other cases, triple vessel diseases, as was discussed. All are complex left main bifurcations, all 3 vessels addressed in the same setting. So we've got about 12 of these. We lost 1 patient to sepsis, and that was actually a mistake on our part because we didn't realize that he was actually incubating an infection at the time of the procedure. We thought the shock was cardiogenic. And by the time we'd done the procedure at the end, we realized that no, he actually had sepsis from a ruptured gallbladder. And so his LV function actually improved, but he died of the complications of sepsis. we've become good at managing our peripherals because of all the experience with TAVRs and TVARs and other things. So our peripherals are not an issue for us at all. But the removal of the Impella, I think, is the one thing where we all need a little help. It's nice to see the experts also having measurements which they'd like to validate. And we pretty much use the same thing. That is the LV-ED levels, the PA SATs, the PA pressures, and the mean arterial pressures, as these are the four. Another thing I'd like to add is the pH, the arterial pH. Sometimes it lags a little bit, but an arterial pH drawn after about an hour of the procedure in our hands seems to be an extremely good indicator. The bicarbonates and the pH are very, very good indicators of the lactates are good indicators of what's happening with the cardiac output. I should be glad for any pointers from our experts.
Great presentation, Ajay, and a great save in what is not an unusual scenario, but the expertise and availability of Impella in your hands really made the day and saved this patient's life. So it brings us down to, let's have a discussion on this. And I would like my discussants to come through with the strategies they would have in mind in such a scenario.
Ashok sir, we have had similar cases, but only thing is, in our place, the availability of Impella may not be immediately. Probably, most of our experience is with protected PCI, where you electively bring the Impella and do. But we have done few cases. Patient, we put them on ECMO and IABP combination, and have done few cases. So, what is your feeling in such an approach for such a case where the Impella is not immediately available? Probably for protected PCI, we can definitely bring it over 24 hours or so. What is your feeling on this?
So this is a very interesting conversation as we come to a shock situation. And Raj, we discussed this as we were creating our consensus on cardiogenic shock in stage C. You remember our conversation whereby we said in stage C, we would actually recommend an Impella, or if we were moving from stage B to stage C and we had to revascularize stage C. And there are Indian centers who are got a greater expertise and availability in ECMO to be able to put a patient on ECMO at that time and therefore do a revascularization. So, Selvamani, you're not alone in this. There is a spectrum of centers who have easy availability for ECMO. They have the care of ECMO, as well as the availability to deload with in IBP after that, as long as you know that this is a short-term ECMO, and as long as you know that you can take care of the patient for a couple of days on that ECMO, you will have a survival. While the data on ECMO relates to not this sort of patient, not this sort of patient, the data on ECMO which did not prove survival, was clearly those patients who were a different subgroup of patients. So I'm okay with what you said if you don't have Impella and have the expertise of ECMO, short-term ECMO at that center to do it safely and effectively and save a life. And we are not talking about stage E, we're talking about stage C. Stage C, which progress to stage D, but not stage E.
So, I think Dr. Seth brings up fantastic points. Ajay, it was a beautiful case, beautifully done. I actually really like the utilization of the DK crush where you use a large circumflex as the main branch. Typically what we see is the highest rates of failure in very calcified disease, even with rota and cutting balloons and everything, is the ostial circumflex. So I know a fair number of operators have utilized that strategy with a lot of success. I know it can be debated both ways. The appreciation for the hemodynamics, the weaning protocols, I think are all fantastically and expertly done. And I think your point that most operators and interventionalists now are becoming more familiar with large bore access because of structural heart disease and doing TAVIs and everything like that. So the mitigation of some of the vascular issues is quite commonplace and really helpful, I think, in managing these patients both short and long term. With regards to the use of ECMO, we have actually started using quite a bit of ECMO in our structural heart procedures in order to do leaflet modifications and different things like that, whether it's Batman, unicorn procedures, etc. And what we've seen is patients are rock solid stable, just like you showed beautifully that the patient had no hemodynamic compromise throughout the procedure. I think that ECMO provides a fantastic level of support for short-term support. However, it's important to remember that you are increasing the afterload on the ventricle. So in certain instances, you can worsen the pulmonary edema and shock-like state without unloading the ventricle.
In fact,
Well,
please go ahead.
Sir, Ajay, you can comment, and then I had another comment for you.
So before we had Impella available in hospital, which we do now for the last 2.5 years, and we still have financial barriers sometimes to using it. This is the strategy that we were using as well. And I must say that we did use, but unfortunately, I do feel that there is a limit to the kind of results that you can get. I think the point that was made that the LVED keeps on going up, and to do a complex high-risk PCI in which you're doing road ablation and you kind of flood the circulation, you raise the LVED, increase the intramural pressure, the perfusion pressures drop. Unless it's a short procedure and you're not going to really place too much of the myocardium at risk, I think the ECMO helps every other organ, but it doesn't help the heart. It's going to help the lungs, and it's going to help the brain, it's going to help the liver, it'll help the kidneys. But the heart has to recover on its own completely if you're going to put in an ECMO. And I think that is something that we need to think about. The Impella, on the other hand, supports and kinds of not only supports the other organs, but doesn't allow the LVED to go up. So I think that is a conceptual difference between the two.
I think we're absolutely correct in everything that we've said. There's no question that the most physiological support is the Impella CP and 5.5 at the moment, and there's no question around that. If it's easily available, if it's readily available, and if the expertise is there to be able to implant it safely as it's a large bore, that's the device to go to. But I tell you, that's why we're discussing all this, that if we have both, it's going to be Impella. But if we didn't have one and we had the other, which is, as you can understand, ECMO is available with a cardiac surgeon available in many more centers than an immediate availability of Impella in an immediate shock situation. You may have it on your shelf, but Selmamani may not have it on his shelf. And it takes time to come for him. It's an easy task to be able to put an ECMO in. He's got a surgeon there, do the procedure, unload the heart with a balloon pump, and by tomorrow get him off it if the patient's recovering and just get him on. So we want to understand every aspect of it while we know that the go-to device is Impella. I just wanted to bring up one more point where I would slightly caution others in believing that if you have a patient on Impella, just like Ajay made a comment, though he didn't mean to, then we could just do anything safely and anything, and we could go in inflating the balloon any number of times and show how uncoupling happens and how coupling. You know what it is? The longer you spend in coronary arteries, and the more you decide to do in the coronary arteries, just because you feel so comfortable that you're able to inflate the balloon into the left vein and nothing's happening and the patient's supported, the more you stun the myocardium. So I just don't want you to move away from the fact that a safe procedure is going to be the shortest procedure with safety without doing too much within the coronary arteries. You will have to have then recovery of the myocardium, believe you me. And that stunning that we cause has taken away my patients' lives of not realizing how much stunning of myocardium I created, which took time to recover. Then after the procedure, the ejection fraction had dropped down by at least multiple notches, which took time to recover, and therefore had to keep the patient on Impella and take him off, and that took recovery time. So for everyone here, I say, just because you're an Impella, you don't become a cowboy, you don't become a cavalier, you don't actually say, I can spend as much time doing anything within the coronary arteries. Your cautions of safe PCI and effective PCI remain. That's how you get your patients out of your lab.
Absolutely right. I mean, I didn't mean it that way. What I meant was that you can modify it the way you want to without being in a hurry. But obviously, you shouldn't take it to mean that you can do anything for as long as you like. I mean, you should respect the coronary, but not fear it. That's what I mean.
Sure.
Dr. Seth, one last comment I'd like to just interject about the utilization of ECMO. Similar to how you had suggested for high-risk PCI, you're placing a balloon pump in terms of de-escalation from a CP to a balloon pump. We've seen a lot of success in weaning patients off of ECMO, utilizing an Impella as a bridge to unload the myocardium after. So if you don't have the device readily available, certainly supporting them for your intervention with the ECMO and then de-escalating is a reasonable strategy as well.
Agreed, and a great comment. Any other discussions? A lot more discussions are going to happen, so maybe we could move on.
Hi, Dr. Tayal and Dr. Sheth, Dr. Harish here.
Yeah, Harish.
How are you, sir?
Very good. Very good to hear you. Very good to hear your voice.
Good question for both of you, sir. So when you de-escalate with an Impella, what are the strategies you follow of balancing flow and reducing the ECMO and raising the Impella flows, and how do you, what protocol do you follow? I mean,
Raj, you say this is the, and then of course you get to a patient who's let's talk about not cardiac shock, but let's talk about the commonest, of course, the supported PCI in the case of bad LV, who had raised PA pressures, who had borderline PSATs, and who had borderline mean arterial pressures to start off with, but was not on inotropes and had multivessel disease. So Raj has already said that, but he wants now to know the it's not the weaning of protocol. It's also what flow rates is he? How do you down your flow rate?
Absolutely. You don't need a lot of flow actually from the Impella while you're on ECMO. So typically speaking, we'll leave the patients on P2, maybe P3.
Raj, I think he's talking about Impella alone, not ECMO to Impella, but
Right.
no, sir, I'm
Impella
talking
and
about
cath
ECMO to, no, I'm talking about ECMO to Impella
Okay.
and then wheeling of the ECMO.
Okay.
Right. So
Okay.
we'll start with an Impella at P2 for the ECPella type support. And then as you decrease your flows on the ECMO and come down closer to 2 liters of flow, we'll go up to P4 and then ultimately go up to P6 or P7, depending on the patient's hemodynamics prior to removal of the ECMO.
Yeah. Okay. I think we'll move up to the next case, and that's Naveen, yourself, protected PCI with Impella, my experience.
Yes, sir. A very good evening, respected chairperson, expert panelist, and all other stalwarts of cardiology. It's an honor and my privilege to present this case before you. My screen is visible to all of you and I'm audible to all of you, sir?
Yes, you are.
So I'm presenting a complex high-risk PCI using single-axis Impella CP. My case is he's a 35-year male presented with acute coronary syndrome, initially admitted to some outside hospital with a 24-hour history of chest pain. He's diabetic, dyslipidemic, and smoker, NYHA class 4. I received at our center intubated on high-dose vasopressor support with left-sided intra-aortic balloon pump. On arrival, he was in shock with a 90/60 blood pressure on high-dose inotropic support, heart rate of 110, SpO2 97%, troponin was positive. Anti-pro-BNP 7,600 picogram and the lactate is 4.5. ECG, there is some coving in the inferior leads with ST depression anterior leads. Echo shows severe LV dysfunction, ejection fraction of 20%. This is an X-ray, so both the lung fields are congested, you can see in this chest X-ray. We managed it conservatively for another 6, 8, 10 hours and then did an angiogram. And this is the angiogram you can see in the RA caudal view. The circumflex is diffusely diseased, OM1, there is a subtotal occlusion of the OM1. Ostial of the OM2 is 95% and there are the 2 tandem lesions in the distal OM3 also. If you see the LAD also, there is a subtotal occlusion in the LAD that is long segment more than 20 millimeter. RCA is free of disease and giving good collaterals to the up to the mid LAD. If you calculate the syntax score, it's around 23% involving the LCX and LAD. RC is free of disease. There is some the long segment lesions, subtotal occlusions, tandem lesions. The syntax score is approximately 23 in this case. So what do you do for such a patient? To summarize, recent ACS severe LV dysfunction, we extubated the patient on NIV. He was on NIV support. Medical manage, I think no. Revascularization is the best modality to treat. Heart team discussion was done. So the two options were there, CABG as well as PCI with mechanical circulatory support. As patient is a young patient with severe LV dysfunction and family don't want to go for the CABG, and the syntax score also favors in PCI. So we decided to go with the PCI single axis Impella strategy, as the left groin was unusable because of the hematoma, because of the IABP was put outside. We used the IVUS imaging also, but we were not able to retrieve the images because of some technical reasons. So before going to put a Impella device, we do a right heart catheterization to know the baseline hemodynamics, RA pressure, pulmonary artery pulsatile index, peer pressures and all. And once we confirm that this patient don't require the RV support, let's go for the Impella device. Right femoral arterial access was done by using the micropuncture needle, using the ultrasound guidance and fluoroscopy guidance, because we are going to put a 14 French sheath, and this was our fourth case only. So we were very careful. That's why we used the micropuncture needle. And because left groin was not available, so we decided to go over the single axis Impella. 2 per close, 14 French sheath. Impella is there in the LV, well placed into the LV. Then we decided to go with the destination sheath. 7 French destination sheath was put through the by using a micropuncture needle in the Impella sheath, and then 7 French guide was placed into the left side. Then we decided to go with the left circumflex artery PCI. The wire is placed into the OM2 and OM3. So OM2 is a not very small vessel, so we decided to go with the drug-coated balloon angioplasty of the OM2 with 2 into 12 millimeter balloon. And the OM3, after the pre-dilatation with the NC balloon, we placed a stent 2.25 into 24 into the OM3. The major challenge was, the going into the OM1, which was one of the important vessel, and was but the takeoff was very, difficult, and the wiring was difficult, but still we were able to cross with the help of using the fine cross wire and the Fielder XT polymer jacketed wire. And after 15 minutes of trying the wiring, we were able to cross the OM1. We decided to go with the after pre-dilatation 2.25 into 38 drug-eluting stent with 2 millimeter hanging to the main circumflex. Then you crushed with the 3.5 millimeter balloon, rewired, kissing done, and then with the help of guide liner, we were able to place a stent 3.5 into 38 into the left circumflex. Then again, rewiring, final kissing, and this is the final result of the circumflex. After the LCX, we decided to go with the LED territory. Then with the help of fine cross, Fielder XT, and then change with the workhorse wire, we were able to cross the LED. Pre-dilated, and then a stent of 2.5 into 38 millimeters deployed. Though the distal LED is a diffuse deceit, initially we decided to go with a drug-coated balloon, but because of some financial and technical reasons, we were not able to do it, and we left it like this only, and we decided to go for the weaning protocol. So Impella was there, patient was shifted into the CCU. So single axis Impella is a technique of placing sheath or guide for PCI to, in this case, patient with a limited access option. So that is why we decided to go with a single axis Impella with a destination sheath, and which was 7 French compatible. These are the intra-arterial axis gain for placement of 14 French Impella sheath, axis gain to the diaphragm of Impella sheath. We all know I am not able to going to show these slides. So sheath options, yes, we have a different sheath options available: panacle destinations, braided sheaths, 7 French bright cook sheath, and longer sheaths are also available. But the potential complication is bleeding from the diaphragm, bleeding around the sheath disruption, lack of second axis to manage the complications, and the movement of the Impella while advancing the sheath. This is a very critical. So we have to fix the Impella shaft while advancing the sheath. So I'm not going into the details. So the conclusion is high-risk PCI and severe LV dysfunction requires precise planning, support, and execution. Impella CP provides effective LV support, maintaining the hemodynamic stability throughout the complex double vessel revascularization, right heart catheterization, guided appropriate MCS selection by confirming the isolated LV failure with preserved RV function. Single axis Impella technique was safe, efficient, and essential. Given the contralateral femoral limitations, complete revascularization was achieved successfully with favorable early clinical recovery. Thank you, sir, and open for the discussion.
Oh, thank you. I think that brings in a new aspect to the discussion. Naveen, that was a great case and single axis impeller. So just tell me, what sheath did you use? Was it a 45 centimeter sheath?
45 centimeter thermo destination sheath.
And a 7 French?
Yeah, and a 7 French.
So I hope everyone understands that when you use a 7 French sheath, I mean, it's great to use a 6 French sheath because you can put the sheath totally in. But a 7 French is very difficult to put totally in because there's an uncoated portion of the 7 French, and that's what I have this real issue that you'll part of the sheath will stay out, and therefore your guide at catheter can fall short.
We were
and
not
you
having that 6 French sheath available with that time. So
right. But that's the thing to keep in mind, that if you're going to use it, I'd rather use a 6 F if the anatomy allowed it. And clearly, or I would have to have a longer guiding catheter, and the manipulations of both devices get a bit limited in a way if we are. So Raj, over to you, because you have a lot more experience on the single axis.
Yeah, so I think it's a great technique with a couple of watch-outs, which you alluded to very, very nicely. They have designed a specific buddy sheath that's called that they have different names, Roadrunner or the companion sheath is one that's made by Abiomed specifically. But those are completely hydrophilic and kind of, allow for complete insertion so that there's not the lack of engagement. There, interestingly, have been a couple of case reports where there have been some left ventricular injuries when people are advancing the catheters in the setting of acute myocardial infarctions, where the pigtail actually interacts with the apex of the ventricle. Because the tendency, if you're not holding onto the device and there's interaction, you're pushing the guide, is for the Impella device to lurch forward. So I really, really encourage that people keep a hand on it and or an eye on it angiographically. I think it's interesting and a telltale of the times, Dr. Seth, that we're seeing a lot of these cases that are bordering, again, on the spectrum of high-risk PCI with cardiogenic shock in the background. So the expert use and recognition of hemodynamics, I think, in both settings is critically important and needs to be recognized. One of the things that's changed in our practice here over the last 3 years is we routinely do right heart caths prior to even just high-risk PCI, non-shock outpatients. We do it just because it gives us a better assessment of the hemodynamics and guides with the weaning protocols. But I think everything was quite nicely done. One comment about closure, one of the limiting steps of only having a singular access is the fact that you won't be able to visualize the arteriotomy after closure. So sometimes what we'll do is we'll use an ultrasound. If you do use ultrasound for access, put it longitudinally, put color on to ensure that there's laminar flow through the artery and no visible, outpouching or bleeding. Obviously, I don't think it's really worthwhile to kind of get contralateral access just to take a look at it. But we routinely have gone to a 1 per close and 1 angioseal strategy, which has really, I think there's data in the TAVI space suggests that there's much quicker hemostasis. A lot of times there's some nuanced bleeding with 2 per closes, but I think everything was beautifully done and well executed.
And also, Naveen, I'd also like to comment on that your case is a great demonstration of a stage C shock. This was a lactate rising. This was a patient in stage C.
Yeah.
You actually did the right thing. And I would just state, you said you stabilized the patient for a few hours. Obviously, you're committed in multiple ways when you say few hours because you have the relatives there, you have to have the implications of the use of a very expensive device and so on and so forth. But on the other hand, yes, You stabilize the patient as fast as you can, but the earlier you revascularize these patients, the better they are. So you're right on spelling out every aspect of it. I must compliment you that you also described the stage C shock. Excellent. And that's the place that you really need to have them in the lab on an Impella to get them out of this shock situation, and you did it admirably.
Thank you so much, sir.
So I think those are the examples. Lactates, by the way, for everything else. You may have the patient on inotropes, so you have three aspects to a shock. You have the hemodynamic, the features, the clinical features of poor output. You have the hemodynamic features of poor output, but lactates is perhaps what you watch out for most.
Yes.
If you see a deterioration from stage B to stage C, is lactates. It's not, urine output may be fine still. You may have others which are borderline. You may have a bit of inotropes on, but that's also that's getting bad. But lactates is what tells you to move ahead and have them on a support and take them for a PCI.
I do agree, sir. Lactates. First thing I would like to see in the ABG is what is the lactate levels, whether they are going up or going down. Yeah.
Good. Any other comments and questions here? If there are none, we could definitely move on. I know that we should be rushing through this agenda a bit more. So let's have a protected PCI from Dr. Shafiq.
Thank you, sir. Good evening. I hope I'm audible.
Yes, Shafiq, you
are. Good evening, everyone, respected teachers. And this is a great opportunity to present my case. I would like now to share my whole screen here. I hope my screen is visible now.
Yeah.
Thank you. All right. So my case, I'll directly come to my case. It's a 59 years old male, long-standing diabetes, peripheral neuropathy with all complications that had. And from 2022, he started having recurrent acute coronary syndrome, hospitalization with end-stage and heart failure, and was diagnosed to have moderate and progressively worsening left ventricular function. And in parallel, he also had peripheral vascular occlusive disease with multiple non-healing ulcers. And he lost many of his digits due to ischemia as well as neuropathic complication of diabetes. So he was in and out of hospital and ICUs because of sepsis, peripheral vascular dysfunction, and his creatinine was always in the range of 2.2 to 3. So initially, in many centers, the angiogram was deferred. And in 2023, one of the center he underwent an angiogram which showed calcific left main coronary artery disease and with triple vessel disease. And considering his peripheral vascular, his poor wound healing, surgeon turned down, and looking at his ejection fraction, he was deemed high risk for PCA also. And he landed in a hospital in acute and chronic kidney disease. His ejection fraction at the presentation showed around 22% with right ventricular dysfunction, severe pulmonary arterial hypertension. And the challenges here was more like a chronic ischemia. There is already a CKD, and he had undergone a couple of times dialysis when in the previous hospitalizations. He had calcific diffuse vessel with poor target vessels, severe left ventricular dysfunction, almost always in NYHA 3 to 4. He was almost bedridden for many months, and very bad iliacs and peripheral vascular disease. And our challenge was planned to get him out of the infection first. So it took almost a month of dressing and stabilization medically. And we treated his leg ulcer. The heart team meeting deemed that the surgery, our surgeon also refused the case. So after stabilization, we planned a myocardial imaging and proved that the LAD and RCA territory are at least partially viable, and the creatinine got stabilized over 2.3. So we then planned possible revascularization with PCI with MCS support. And we discussed Impella CP versus ECMO. Regarding the coronary ablation, it was rotational atherectomy combined with lithotripsy with temporary pacing and all sorts of debulking technology with backup. So these were the coronary anatomy that you can see here. So there was a heavily calcific mid-shaft left main stenosis with diffuse proximal LAD, calcific stenosis, and a diffusely diseased right coronary artery with near total in the mid portion with competitive flow in the distal RCA. Circumflex was small and not very commendable. And this was planned as an elective case after stabilization. So as we planned at the time when we were doing TAVI with 2 proglides, so we put 2 proglides for Impella, and Impella Smart CP Smart was advanced and started functioning, and we decided to tackle the right coronary artery first. It was calcific, nothing was going inside, so we had to do the primary wiring with the rotor wire. And after that, atherectomy was done with a 1.5 millimeter bar. It took some time to get into the distal RCA, but after that it was easy. And then we dilated with serial with non-compliant and then Wolverine cutting balloons. And right coronary was stented with 2 long everolimus saluting stents, and this was the final result. In the same sitting, he was stable at that time. So in the same sitting, we went ahead with the left main angioplasty as well. And this was the left main shoot. So we took the same bar. This time we went a little faster, 1 minute, and you can see the classical ventricular arterial decoupling here. And after the dilatation, we prepared the LAD bed first, and the preparation was confirmed. And you can see the in the IVUS, there were sufficient cuts in the LAD. The calcium, the 360-degree calcium was sufficiently broken after the preparation, and then we started deciding, started dilating the left main. And after the initial balloon dilatations, we took a 3.12 millimeter shock wave and delivered 8 pulses. So initial pulses we gave for 5 seconds each, and then then we started delivering 10 pulses each, and then patient was quite comfortably stable, but even though there was significant ventricular arterial decoupling. And after the balloon IVL, and we put a 3.5 NC balloon, and sorry. So just wanted to demonstrate the result that we got in the IVUS. And in the left main, you could see that the cracks that we achieved. And after the adequate preparation of the bed, we decided to stent. This was the result after debulking, and we put 2 overlapping stent, everolimus eluting stent, from the mid to distal LAD to the proximal LAD. And circumflex was small and it was flowing, so we did not bother about recrossing. And now you can see that was the final result. So this was the final result, and we got a reasonably good flow. And the most important thing was the patient was stable throughout the time under conscious sedation. So we started weaning off from Impella immediately after a procedure, and it took around 45 minutes to 1 hour. And the opening PA pressure was 80/55, and the mean arterial pressure was 80. And when we finished the procedure, the PA pressure was mean PA pressure was 36, and the mean arterial pressure was 90. And over a period of time, he required inotropes for another 3 to 4 days. He was out of ICCO in 7 days. On 13th day, he was discharged with a ejection fraction of 30, a PA pressure of 50, and a creatinine of 2.2. Over 1 month, his creatinine dropped to 1.6, and ejection fraction was 40. Now he's ambulant. We restarted RNA again, and now we were able to stop. He's on a loop diuretic. His RV function is still not fully recovered, but the left ventricle function has recovered significantly, and he's very ambulant. He never had a hospitalization after that. It's almost 8 months now after the procedure. And this is the current ejection echo. And just to conclude, these type of complex cases can now be considered for PCI or revascularization with available mechanical circulatory support. There are various combinations, as we had all the discussions in the previous sessions, and it is all about meticulous planning and execution in terms of if it is a chronic coronary artery disease. And it is extremely important to have support system in all other systems as well. And Impella, of course, it's a very valuable addition in selected cases. Thank you. Thank you so much for patience.
Shafiq, I mean, this was another just absolutely incredible case demonstration with the appreciation for the hemodynamics and appropriate vessel preparation, intravascular imaging, all the things. I think the final result was gorgeous. I will pause it and just say that there's been this strong movement where everyone has been so hyper-focused on achieving complete revascularization. And I think it's a key thing within reason. I think when people are facing chronic kidney disease, sometimes we need to keep that in mind and consider staging things too. There's no harm in doing that in some instances, but it looks like you were able to achieve everything you wanted to with a reasonable amount of contrast, and as evidenced by the patient's recovery of their renal function. Again, just I think it was well done.
Thank you.
Dr. Seth, I think you're on mute.
Thanks, Raj. So I said, there's another predicted case, PCI case by Dr. Dhananjay Kumar, and maybe you could have some discussion after that. So Dr. Dhananjay,
Yeah. Good evening, sir. Good evening, Tal, sir. I am fortunate to have this opportunity to present in front of you. I'm going to share my screen. Am I visible?
No, your screen is not yet visible.
Okay. Is that?
It is visible, and you can go to the slideshow mode.
Okay, sir. Yeah, sir. Sir, I'm Dr. Dhananjay. I'm working in Medica Hospital, Ranchi. This is about excuse me. A 70-year female presented with 4 hours chest pain and shortness of breath. She came to our emergency at around midnight, 12 a.m. She was a hypertensive dyslipidemic but non-diabetic. Her heart rate at presentation was around 118 to 120 per minute. Systolic blood pressure was around 70 mmHg. Her respiratory rate was around 22 to 28 per minute, and she was maintaining saturation of around 88 to 90% on full oxygen. Her ECG was suggestive of interval MI, and echo in the emergency room showed ejection fraction of 30% with almost a stunt LAD territory with mild MR. So we opted to for primary PCI. Her NGO was suggestive of thrombotic occlusion of LAD with critical stenosis in LCX and RCA. So we immediately put her on IABP. We didn't have Impella support at that time. So we put her on IABP and started the primary PCI. The primary PCI outcome was good angiographically. It was TIMI3 flow in distal LAD. But the LAD ostium was also diseased, not to the significant level. So I opted to stent the segment from the proximal healthy looking zone to the mid part with a small stent. And this was her post-primary course. Her chest pain subsided, breathlessness persisted, needing NIV support off and on for a few days. SPB, systolic blood pressure remained around 100 mm of SG on IABP plus inotrope supports. ST elevation settled to some extent. Echo remained the same. EGFR was preserved. SGPT-SCOT was mildly elevated. Lactate, although I have not mentioned in this chart, but lactate was also normal. Even after 3 days, any attempt of weaning from IABP, BP was falling further. That needed up titration of inotropes, but we opted to remove the IABP on high dose of inotropes on 4th day because of her inability to lie down in same posture for 4 days, and we were not in decision to put her on sedatives. So we removed the IABP and gradually we started to taper down the inotropes, but it was not possible for us to completely taper it off. And sometimes after tapering one of the inotropes, the BP was going drastically to the very lower level, and then the cycle was like we again have to increase the inotropes, then again starting titrating that, and again some episode of hypotension. So it occurs around 3 to 4 times in those 3 to 4 days. So we took advice from the CTVS, but they refused to operate in such high risk condition, and even relatives were not ready to take such high perioperative mortality risk. So we opted for complete revascularization with Impella's CP support, and we after Impella implantation, we started with RCA. RCA was calcified, although it yielded with cutting balloon. The mid part of the RCA was around 180 to 270 degree of calcium was there, but it yielded with cutting balloon, high pressure cutting balloon with 0.75 to 1 ratio in cutting balloon to at around 20 atmospheric pressure. So it yielded well. Then we are stented with 3 into 38 drug-eluting stent, and the outcome was good. Even we saw it with this IVAS, and the stent was well opposed, and the luminal gain was optimal. So then we started PCI to LCX. LCX was critical, as well as it was not taking any hardware after the wire. So we took a balloon to the LAD stented segment, anchored there, and then everything was going smoothly. So again, the segment was calcified. The mid part was sorry, this segment was calcified more than 180 degree, but again it also yielded beautifully with the high pressure cutting balloon. And the good part was that the proximal segment, the proximal 10 mm of the LCX was disease free. So we opted to just stent the leaving the ostium without a stent. And this was again, the outcome was good. We checked it with IVUS, and then we did the IVUS to the LAD segment. The LAD, the LAD stent was well opposed, although we have not post dilated the segment on the day of primary PCI. So it was it needed some post dilatation, but the proximal segment of the LAD, where we have left the proximal stent studs, was at the fibrous plaque of around 60%. And the LAD ostium had significant fibrous plaque, more than 70%. And that left main ostium also having 20 to 30% plaquing, and the length of left main was around 8 to 9 mm. So we decided to do a stenting, although we were trying to cross over the stent from left main to LAD only, but as we have the smallest balloon size of 8 mm, and the left main segment was small, and the proximal segment was lying on the left main ostial plaque. So we decided to cover the left main ostium, and after post dilatation of the initial stented segment, we gave cutting balloon to the left main LAD ostium as well as the left main ostium, and then stented with 4 into 24 drug-eluting stent overlapping with the previous stent, and then post-dilated with 4.5 into 8 at the high pressure, 24 mmHg, 24 atmospheric pressure, and then this was the outcome of this. This was the IVUS stent. It shows well opposed stent studs as well as the well covered left main ostium. Carina was also maintained, and LCX didn't pinch. So after that, we left the Impella as such, and in the morning, patient developed chest pain. It was not like chest pain of coronary origin. It was like parietal origin, and any in movement of Impella, the pain was subsiding, and then again it was recurring. So we decided to remove, because this was the first Impella case at my center, and my technicians as well as the nursing staff were not well oriented with that. So I decided to remove it, so that, and the requirement, ionotropes requirement was has already been decreased. So I decided to remove the Impella on that day, and this was the post revascularization course. After 16 hours of we removed Impella, ionotropes tapered off gradually in 2 days. Creatinine settled down to 0.6, although it was 1.3, 1.4 in between the days. And liver enzymes also improved. Patient discharged on the 5th day. She is doing well. It has now been 8 months, and her LVEF and GLS has improved to some extent. The EF was initially 30%, that has improved to 40%, and GLS that was initially minus 6% to that has improved to minus 11.5%. So thank you so much, sir, for giving chance to me.
Thank you, Dhananjay. I mean, I can only compliment and congratulate you on a very difficult circumstances. I must say that it's heartening, and it's a very different experience to see the fact that this young Jen, Dhananjay, yourself at Rachi, has such complex patients, and you think through systematically and be brave enough and competent enough to actually take a patient through meticulous revascularization, a complete revascularization, and save a patient's life. I think that's the changing India. To see cardiogenic shock and lives in cardiogenic shock being saved at not the super specialist tertiary centers, but also in the secondary centers and through through enthusiastic courage, meticulous, and, by the way, contemporary PCI. That's what I would say. You practiced contemporary PCI. You did imaging. You looked at every aspect of giving the best outcomes. There's a lot to comment on how you took everything through, but it's also a lot to comment on how India is changing through people like you. So that's my compliment to you. And I'm now not going to comment on the case because I think we've commented on the cases, but I think all of you who presented the cases deserve a round of applause, not just because they were seniors, they were juniors, they were all across the spectrum, but each one of you showed how you can take care of these very sick patients with competence. Raj?
Thank you, sir.
I couldn't say it any better myself, Dr. Seth. I mean, it's just world-class care. I mean, you're seeing cutting-edge care being delivered in the most dire of circumstances. A lot of these patients were literally no-option patients that would have died under any other circumstance. And not only were they treated appropriately, but they had fantastic outcomes that were durable. And I think you guys are really pushing the field forward and really standardizing care across the globe. So kudos to everybody for continuing to push forward. This is the future. And I strongly believe if we keep up the current workflows, the gap between us and the delta between intervention and coronary artery bypass grafting will continue to decrease, and the outcomes will continue to improve even in the sickest of patients.
Thank you. But those last words from Raj, if there are any comments from any of my colleague panelists, any closing remarks, I'd be quite happy to take them.
Yeah, I think this is a classical situation where we have certain limitations in the sense that you have STEMI, you have to immediately open the artery, and sometimes you don't have Impella on shelf. So that's my protocol also, immediately open the vessel and then later on put Impella and complete the revascularization, because most of these shock patients, they do not recover unless you provide complete revascularization. And all literature has also said that the outcomes are far better, whether you take into account SCAR trial or pre-combat or Syntax data. It's clear that unless you do complete revascularization in these patients, the long-term outcomes are not good. So we have also at times, customized our approach by doing, STEMI coming at the middle of night, do it, and then the rest of the revascularization can follow the very next day with the MCS.
With any last comments? We're much over time, so I think from my side, I just say, great job. What a great evening. Impella is certainly a go-to device. Actually, the only proven mechanical circuitry support that we have in our hands for both protective PCI and certainly for cardiogenic shock. And I think we should just see more of it used. And I thank J&J and Veiva Medical for organizing this. But I'm sure that we'll have more interactions in seeing how to make it more available and affordable for our patients and for many of the centers who would love to save lives in the circumstances of financial constraints that exist in India. But at least the training programs are going well, and we hope to see great more lives being saved. Thank you very much, all of you. Thanks, Raj. Thank you for being there.
Thank you, sir. Thank you, sir.
Thanks a lot, sir.
Thank you so much, sir.
Thank you.
Thank you, sir.
Thank you all.
Yeah.
Thank you, sir.
On behalf of Veiva Scientific and J&J MedTech, I extend our heartfelt thanks to everyone who joined us today for this insightful session on the Impella device, and a special note of gratitude for Dr. Ashok Seth. It was an honor to have you, sir, and have your presence and expertise leading today's forum. Our sincere thanks to our keynote speaker, our esteemed panelists and speakers as well. We truly appreciate your time and knowledge that you shared with us today. We look forward to bringing you more such forums in the future. And until next time, thank you once again. Have a great evening. Thank you, sir.